Hello, I'm Dr. Robert Kaufman, and we're about to go beyond the terminus. When you consider endodontic treatment for a patient, occlusion issues generally aren't the first thing that you survey. Most often it's about the caries or the remaining tooth structure. But maybe we need to give occlusion more importance. It's very common to have patients referred that have tilted teeth where the dentist has been struggling to close contacts and prevent recurrence of caries under deep proximal restorations. In other situations, crowding, rotated or unfavorable position makes it almost impossible for you to optimally restore the tooth and for the patient to maintain hygiene. So while devitalizing the tooth with endodontics helps solve this problem. In cases with heavy wear in the anterior segments of the mouth, we frequently see pulp exposures and loss of pulp vitality through attrition. While the endodontic treatment may solve the periapical infection problem when it's present, what about the adjacent teeth that are destined for similar treatment? Do we wait until they become exposed as well? It's the referring dentist's responsibility to recognize this and try to find a solution, or at least discuss the etiology with the patient. Post-endodontic restoration of lone-standing molars is also always a concern. Unaccompanied or lone-standing teeth with 2 or 3 surface proximal restorations have a very high rate of mesial-distal catastrophic fracture. Delay in restoration of even a few weeks can result in a split tooth and loss of the patient's investment. So if you're going to treat or refer a case like that, arrangements must be made to properly temporize the case, either with an occlusion-relieved core at the time of endo treatment, an ortho band or a copper band, or some sort of temporary crown, or get them in right away for restoration. Yeah, I know, insurance considerations sometimes heavily influence patients' decisions, but that will be cold comfort for them when the tooth cracks and their initial endo investment ends up in extraction. Closing contacts is also very important. Truth be told, posterior composites have literally saved endodontics. Practices that have moved away from amalgam, a material that allows for making proximal contacts relatively easily, often have difficulty with matrices that cause parallelism in the proximal contacts. Where 2 adjacent teeth are restored, it makes little sense to restore only one surface optimally while leaving the other proximal flat surface to cause food impaction and have a light or open contact. Eventually, the deep, sometimes subgingival proximal decay that results necessitates elective endodontic treatment because it encroaches on the pulp. Tooth is restored, there is the added advantage of now having a non-vital tooth that cannot sense decay. When we add the cost of the potential crown lengthening into the fee equation, we have to ask ourselves whether restoration and rehabilitation of such a compromised tooth represents a good investment versus that of extraction and implant replacement. That should not be something that is left to the endodontist to decide. These problems need to be recognized and discussed before referral. Think about the materials that you're using to restore these teeth. If the patient has a history of fracturing proximal boxes, grinding through the isthmus, or failure of the material through occlusal forces, maybe we should consider cuspal coverage with a stronger, more durable material. Lastly, the hygiene issue. Who knows the patient best? That would be you, the referring dentist. As an endodontist, I'm not seeing the patient regularly, so it's really unfair to refer patients with poor hygiene. Recurrent caries and coronal leakage can cause endo failure, something that we endodontists have absolutely no control over. So rather than simply referring the patient because they may be symptomatic or because the radiograph shows a radiolucent finding at the apex, we need to think about the end results first. How likely is it that the patient will be able to maintain and keep the tooth long-term? Is investment in this tooth justified? As the patient's general dentist, that's a question that you need to answer before the case is referred. Examination of the occlusal relationships should be a routine part of the initial examination and decision to rehabilitate or to extract. Remember, when we do the right thing, we both get better, patients and clinicians. That's it for now. Join me again on our next trip when we go beyond the terminus.